Good morning, everyone. Today we are going to discuss about acute appendicitis. A lot of the students have been asking about acute appendicitis, acute cholecystitis, and the other topics. Step by step, we will discuss all of those topics in the near future. So today we will discuss about acute appendicitis. Now, this is a very large chapter. It's quite difficult to discuss every aspect in 1 hour, but I will try my best to discuss the things that is mostly needed in an undergrad level. Okay, so firstly, there is some anatomy. Now, this is the appendix, right? This is the cecum, the terminal ileum, and this is the mesoappendix. The appendicular artery comes from the free border of the mesoappendix and gives blood supply to the appendix. These are the preliminary things, and I'm sure you all know about this. What are the common positions of the appendix? This is very, very important because the position, according to the position, the signs and symptoms of the disease changes. Also, as a surgeon, you'll all know that sometimes the appendicectomy is quite simple because you easily find it, and sometimes it's quite difficult. Sometimes even you have to mobilize the cecum. So this all depends on the position of the appendix. Now, commonly the appendix is found in the retrocecal position. This is common. The pelvic is the second most common, and then the others that comes. Now, if you see the retrocecal appendix, if you even in a laparoscopic or in an open setting, you find an appendix in a similar situation, you may have to mobilize the cecum. On the other hand, the features of the appendicitis changes with the position. For example, if you see an appendix in somewhere around the ileum, there may be an intense retching and vomiting of the patient because it irritates the ileum. If you see a pelvic appendix, it may sometimes irritate the rectum and cause diarrhea or tenesmus. So these are the features also changes with the position of the appendix. As you can see, the retrocecal appendix, the commonest 74%, and the pelvic is the second commonest position, and then the other comes. Now, appendix is round about 6 to 10 centimeter at an average of 11 centimeters. The range can be from 2 centimeter to 20 centimeter, and diameter is something around 10 millimeters. Anatomy, most important is it is found in the posterior medial wall of the cecum. This is the commonest position when you do the appendicectomy operation. We usually follow the tinea, and we find it somewhere near posterior medial wall of the cecum. There is a valve, the valve of Garlack, which in the appendicular orifice, when the appendix opens into the cecum, there is a valve. It can be a physiological, I don't know, it does not have a lot of significance, but you should know that the name of the valve is valve of Garlack. Then there's a mesoappendix, which is of particular importance when you are doing the appendicectomy operations. Certainly, the blood supply is of immense importance in any surgery we want to do. As you can see, this is the aorta. From the aorta, the superior mesenteric artery. And one branch is the ileocolic artery. And another branch from the ileocolic artery is the appendicular artery. This runs in the free border of the mesoappendix, which is very important, which commonly is asked by the examiners in the examination. Again, another picture. As you can see, the artery runs in the free border of the mesoappendix. Appendicular vein, which is a branch of ileocolic vein, which is again a branch of the superior mesenteric vein. This is important because if we should remember, the appendix is ultimately drained by the portal system and it goes into the liver. So one of the complications of appendicectomy is portal appendicitis, is portal pyemia. That means in the portal blood there is septicemia in the portal blood. This is how it happens. The infection or the bacteria or the microorganism travels through the appendicular vein to the ileocolic vein, then to the superior mesenteric vein, into the portal vein. Nervous system. The nervous system derives from T9 and T10. Excuse me. Sorry for that. One of my SARS calls. Okay, anyway. So, sympathetic nervous system is derived from the T9 and T10. Now, if you remember from our first year anatomy, if this is the umbilicus, the dermatum of the umbilicus is T10. So this is another thing that is we have to keep in mind, that the dermatum, the somatic supply of the umbilicus is T10. On the other hand, the autonomic supply of the appendix is also T10. So what happens is whenever the appendix is inflamed, the brain thinks as if the pain is coming from the same somatic supply, that is T10. That is the uh, explanation to why there is a periumbilical colic initially in a case of appendicitis. The parasympathetic nerve comes from the vagus nerve, we all know that. Now, another thing about histopathology is there are a lot of crypts in the appendix, and within the crypts there is there are cells called Argentifen cells or Kalchutsky cells. Now, these cells give rise to carcinoid tumors. If you remember, appendix is the commonest site. It's the commonest site of carcinoid tumors in the gut. Carcinoid tumors. Carcinoid means they are tumors which which similarly to carcinomas, but they are not carcinoma. Maybe in another class we will discuss about these tumors. Okay, so what are the predisposing factors? Usually, as you know, the appendicitis is a disease of the young. Usually, young patients are suffers from appendicitis, but definitely elderly population can also suffer from it. This is an important point. So you remember, if a patient, someone who is above 50 years, comes to you with right iliac fossa pain, before doing the appendicectomy, make sure that you exclude whether the patient has other problems. For example, a carcinoma cecum, which may also give features similar to that of appendicitis. So a colonoscopy may be helpful in this case. So before doing any elderly patient's appendicectomy, always remember that carcinoma cecum has a feature similar to appendicitis. Lymphoid hyperplasia is another problem, because if you remember, if this is the appendix has got similar, if there are lymph nodes, the lymph node, if there's lymphoid hyperplasia, it blocks the area. As a result, what can happen is there is edema of the appendix, and the bacteria over here, they start to grow all over the place. And as a result, the blood supply also is hampered because of the edema. And what can happen is the tip of the appendix may become gangrenous. We will discuss all of this. Causes of appendicitis. Now, obstructive causes are the commonest cause. The feculite or strictures. These are the commonest cause of appendicitis. which causes bacterial proliferation. One of the intestinal parasites are also important, which is Oxyris vermicularis, or the pinworm. Tumors are sometimes also important. Fibrotic strictures are also important. Now, what is a feculite? Feculite, this is a composition of bacteria, calcium, phosphate, epithelial debris, inspissated fecal matter, and foreign bodies. This is a composition of feculite. Pathology. As I've already discussed, the most of the times the appendix has the vermiform appendix. The appendix looks like a worm, right? So it has got obstructive features. It has got a very, very narrow lumen, which is easily obstructed, which can easily be obstructed. So whenever this is obstructed, let's say from a particular position, there is edema and stasis of bacteria, and which as a result may result into acute appendicitis. If you remember, the blood supply goes to the tip. If the blood supply is hampered, the tip becomes gangrenous, and as a result, burst appendix can happen. And whenever there is a severe infection, inflammation, what happens is the greater omentum and the ileum and all other parts come to this place and forms a big lump. This is called appendicular lump. That can happen as well. We will discuss this in this future. So this is just in short what happens in case of appendicitis. You see the mucus and inflammatory exudates, the obstruction of the lymphatics, bacterial translocation, there is edema, venous obstruction, and as a result, acute appendicitis. This, if the ischemia continues, there will be necrosis, and then there will be a gangrenous appendicitis. As a result, there will be perforation into the peritoneal cavity, and this may result into peritonitis. Ultimately, the greater omentum and the loops of small intestine will come and they will wall off. They will wall off the spreading peritonitis, and there may be an abscess, there may be a mass, or there may be a lump, or the appendicular lump. What are the risk factors for perforation? As usual, extremes of age. So elderly patients or even younger patients, they can have perforation. Immunosuppression like diabetes mellitus, feculite obstruction, pelvic appendix, previous abdominal surgery. Why these are important? Because in these cases, the greater omentum cannot come and reach the appendix. The greater omentum, if you remember, the greater omentum has to reach the appendix to wrap it up. So if it's a pelvic appendix or the previous abdominal surgery, the greater omentum may not be able to come and wrap it up. So as a result, the perforation and the further complications of appendicitis may easily continue without any protection to the patient. Now the most important things, the clinical features. If you remember, this is the classical feature of initially there's a periumbilical colic, and then the pain shifts to the right iliac fossa. So often the patient, what the examiner asks about ask the students to describe the classical pain of appendicitis, and often the student is confused how to really describe the whole thing in one sentence. So this is one way of saying this: sudden periumbilical colicky pain, which shifts to the right iliac fossa, becomes severe constant pain. Initially it was a colicky pain, later it becomes a constant pain. It lasts for hours, aggravated by coughing or movement, relieved by strong analgesics, and associated with anorexia, nausea. So all the points you have discussed. You have discussed about the site. Where is the site? Initially periumbilical and then the right iliac fossa. Onset is severe. Character, it is initially colicky, later it becomes constant. Intensity, it is severe. Radiation, there is, it usually, this is not really a radiating pain. This is called a referred pain. Remember this. This is a referred pain. This is a referred pain. This also is a shifting pain, but not a radiating pain. This is a referred pain. Why this is a referred pain? I will discuss this. This is a shifting pain. Why? Because initially the pain was in and around the periumbilical region, which shifted to the, which shifts to the right iliac fossa. And when it shifts to the right iliac fossa, usually the periumbilical pain is no longer felt. So it has shifted the pain. And why this is a referred pain? I'll discuss this. Remember this is associated with anorexia, nausea, and vomiting. Why this is a referred pain? If you remember, initially the inflamed appendix, the nerve supply, the sympathetic nerve supply, sensory nerve supply goes to the spinal cord and goes to the brain. Now what is the brain thinking? What happens is, this is an autonomic supply. This is an autonomic supply. Now this poorly localizes the pain. This poorly localizes the pain. The brain cannot perceive where the pain is coming from. So what happens? The brain interprets the pain is coming from a somatic nerve of the same spinal segment, which is the T10, which is the dermatum found around the umbilicus. Again, the appendix is supplied, the sensory nerve supply of the appendix is by the autonomic supply of the sympathetic segment, that is T10. Now, when this pain reaches the brain perceives or interprets that the pain is coming from the equivalent spinal segment or the equivalent somatic supply, which is the T10. This is the classical symptom or the classical features of the pain of the appendicitis. This will be asked each and every one of you who will be describing this pain. So a very nice explanation is expected from everybody. Classical symptoms. Now remember this. Always these classical symptoms are not present in 100% of the patient. Mostly a third of the patient comes to you with the classical symptoms. Most of the patients do not give features similar to this. And also there are atypical presentation. In case of elderly, where it is poorly localized pain, the elderly cannot usually describe the pain very well, and it says the pain is all over the abdomen. If there's a pelvic appendix, there may be suprapubic discomfort, there may be tenesmus. This is why we must always do a digital rectal examination in any abdominal patients. What are the clinical signs? Pyrexia, there is fever, which is usually low grade, until and unless if there is some abscess formation, then it becomes a high grade fever with chills and rigor. There's definitely localized tenderness. There will be muscle guarding. There will be rebound tenderness. Rebound tenderness is a sign of peritonitis. When the parietal peritoneum is inflamed, there will be rebound tenderness. Robson sign, I will discuss this. Suas sign, Obturator sign, and post-ileal mark-retic. If there is a post-ileal, if you remember the different positions of the appendix, if there's a post-ileal appendix, then there will be marked retching. Okay. So, number one is the pointing sign. If you ask the patient to point out where exactly the pain is, usually the patient will be able to point it towards the McBurney's point, which is a point which is at the midpoint of 1/3 and 2/3. If this is the umbilicus, and if this is the anterior superior iliac spine, and if you line it, if this is the spino-umbilical line, it is usually at the junction of medial 2/3 and lateral 1/3. This is the point called McBurney's point. McBurney's point, and this is the point of maximum tenderness. Robson sign. What happens is if in case of acute appendicitis, what happens is usually the inflamed appendix is over here, right? But if you press somewhere around here, the intestine will be shifted, or the abdominal contents will be shifted, and they will push the inflamed appendix, and this will cause pain. This sign is called Robson sign. That means palpation over the left iliac fossa causes pain in the right iliac fossa. This is called Robson sign. Suas sign. What happens is when sometimes, especially in case of pelvic appendix, now if this is, let's say if this is the Suas major muscle, and if the appendix is lying over the Suas major muscle, what happens is if you stretch the Suas major muscle by extension of the hip joint, there will be pain. There will be pain. Usually in the retrocecal type of appendix, this causes pain over the Suas major muscle, and this is called Suas sign. Extension of the hip joint causes pain. Usually the patient, you will see that the patient is in a flex position. Usually if this is the patient's abdomen, patients usually is in this position because of the Suas major muscle. They want to relax, keep the Suas major muscle relaxed. Then the obturator sign. Sometimes in a pelvic appendix, if the appendix is over the obturator muscle, especially internal obturator muscle, what happens is if you do an internal rotation of the hip joints, then it will result in tenderness. It will cause pain to the patient. If you look at this, if you do an internal rotation, passive internal rotation, and then it causes pain, because if you look at this, the appendix is over the obturator internus muscle. So if you stretch the obturator internus muscle, this will cause pain to the patient. This is called obturator sign. This is usually in case of pelvic appendix. Any coughing or any other thing that causes pain, any sudden movement causes pain, even around the right iliac fossa. Localized tenderness at the McBurney's point, we have just discussed. This is a point which is 2/3 and 1/3 junction. 2/3 from the umbilicus, 1/3 from the anterior superior iliac spine. McBurney's point tenderness, we have discussed this. Differentials of the acute appendicitis. Now, there are many differentials. You don't have to learn all of them, but it's very important that you know the important ones. For example, ureteric colic, it's quite common. Right-sided pyelonephritis, common. Perforated peptic ulcer, torsion of the testes, these are very important. And sometimes acute pancreatitis, quite difficult to diagnose as well. In female patient, make sure You do a pregnancy test, very, very important, because ruptured ectopic pregnancy is quite common. Torsion or rupture ovarian cyst, very important. Urinary tract infection, this is also important. Must exclude by do a urinary CS. Do an ultrasound. In female patient, never go for appendicectomy without doing an ultrasound of the abdomen. Do a urinary as well for this patient. Very important in case of female patient. Make sure you always take a history or the menstrual history. Very, very important in female patients. In children, gastroenteritis is quite common, very important. Mucous diverticulitis, intussusception, these are very, very common. Mesenteric adenitis, I have seen a few patients of this as well. In elderly patients, we have already discussed, remember this, carcinoma of cecum, this is the most important one. Mesenteric infraction, this is many a times I have seen that there is always a confusion. You open the abdomen and you see gangrenous bowel. And if you are not prepared for this management of a gangrenous bowel, then it would be a disaster during surgery. So always remember, especially in elderly patients, in an abdominal pain, think about mesenteric infarction. Diverticulitis definitely important. Intestinal obstruction can happen as well. So what investigations? Remember this, that usually in males really, the diagnosis is a clinical diagnosis. But also normal appendix is removed in 30% of the patients. Full blood count shows a neutrophilic leukocytosis, very important. You can do an abdominal x-ray, certainly if you suspect of intestinal obstruction or an ureteric colic, in which you will see, in case of ureteric colic, you may see some stones in the KUB region. In case of intestinal obstruction, you may see the features of intestinal obstruction like dilated bowels, air fluid levels, and other features that we will see in case of intestinal obstruction. Ultrasonogram, always in case of females, always do this. Urine analysis, always do this. Now, the best investigation nowadays for appendicitis is contrast enhanced CT scan. This is the best investigation. If you have any confusion, do this. Pregnancy test, female in the reproductive age, always do this test, always. Colonoscopy, especially in the elderly patients. Alvarado's scoring system. Now, this is not that we always use it, but it's worth remembering the features of it. And I think in clinical setting, you should use this. It really helps. Basic things are the similar to what we have just discussed: the migratory right iliac fossa pain, anorexia, vomiting. These are the symptoms. Signs are tenderness in the right iliac fossa, rebound tenderness, and elevated temperature. Now, if you look, the tenderness in right iliac fossa is given 2 points. That means it's a very important point. And laboratory finding is leukocytosis, especially neutrophilic leukocytosis, which is again given 2 points. So these are the two very important points. In fact, most of the time in a male patient, if you get tender right iliac fossa with neutrophilic leukocytosis, you can be very sure that this is a case of acute appendicitis. Now, the total mark is 10, and out of 10, 7 is 7 strongly indicates towards acute appendicitis. 7 to 10 is strongly predictive of acute appendicitis. Now, treatment, if you remember, all treatments, it starts with resuscitation of the patient. You give the patient nothing per oral, fluids, analgesics for pain, antibiotics. You can give ceftriaxone, you can give ciprofloxacin, and metronidazole. These are important, appropriate in antibiotics for this case. And appendicectomy, if you think there's an appendicitis, do it as early as possible. Indications of appendicectomy. Acute appendicitis, definitely. Recurrent appendicitis, mucosal, and if there's a carcinoid. Incisions. What are the incisions? In fact, there are many incisions that can be given in case of appendicitis. If this is the abdomen of the patient, the gridiron incision is the commonest incision that is given. If this is the right anterior superior iliac spine, and if this is the umbilicus, and if this is the McBurney's point, usually this is a gridiron incision. This is given perpendicular to the uh, spino-umbilical line. This is a muscle splitting incision. Remember, muscles are not cut. Muscle splitting incisions. The Lange incision is more horizontal. So around about the same place, but it's more horizontal. This is the Lange incision. Rutherford Morrison is an extension of the gridiron incision, but it is a muscle cutting incision. Remember this. This is a muscle cutting incision. Certainly, we can give a midline incision if it's a confusion, lower midline incision. Lower paramedian incision can also be given in these patients. Now, these are some of the pictures. Not very. Nowadays, there are a lot of videos of appendectomy in the YouTube. Go check it out. Another, this is a very important picture. Always remember the appendicular artery runs in the free border of the mesoappendix. So you must ligate this. This is ligating the base of the appendix, crushing, barring the appendicular stem. So the points, sometimes they will ask you about the different steps. So remember that you give the incision, preoperative preparation, you give the incision, follow the tinea coli. If you remember, if this is the cecum, and if these are the teneas, ultimately wherever the tinea meets, that is where the appendix is. So you get one tinea and follow it, you'll always get at the end of the tinea, there is the appendix. Ligate the appendicular artery, crush the base, ligate the base, and then you divide it. Clean the stamp with betadine. Purse string suture, nowadays we do not do this, but if you have any confusion, you can always do this and close the wound in layers. Now, if the cecal wall is edematous, don't take the purse string suture. If the base of the appendix is inflamed, do not crush the base. If the appendix is gangrenous, do not ligate or crush. These are a few things, these are technical things which will not be asked in undergrad level. Usually, if these are asked, the examiner will give you some very good marks. What are the complications of appendicectomy? Certainly, intra-abdominal abscess is one of the commonest. Pelvic abscess. Which is drained parectally. Ileus can also happen. That means intestinal obstruction. Adynamic intestinal obstruction can happen for 1 or 2 days, but usually they are recovered. But if there is ileus for lasting for more than 4 or 5 days, definitely other causes should be looked for. Respiratory complications, DVT embolism, always all complications of abdominal surgery. Portal pyemia, if you remember, we have just discussed, the appendicular vein drains into the ileocolic vein, which is a branch of superior mesenteric vein, which drains into the portal system. So septicemia in the portal venous system. This is commonly asked in the examination. So just remember to say it's a case of septicemia in the portal venous system. Definitely, it's one of the commonest late complication is adhesive intestinal obstruction. Usually, this doesn't happen, but if there is an extensive infection, there is a chance of post-operative adhesive intestinal obstruction. Fecal fistula. which you will quite see in a number of patients. Some patient which has been done in the very peripheral parts of Bangladesh and did not maintain proper hygiene or proper aseptic condition, there is a chance of fecal fistula, which usually can be treated conservatively. Richter's hernia, sometimes in laparoscopic surgery, part of the bowel may enter into the laparoscopic port and cause Richter's hernia. Appendicular lump. What are the parts of the appendicular lump? The cecum, the terminal ileum, the omentum, loops of intestine, ascending colon, adjacent peritoneum, and most importantly, the appendix. They together forms the appendicular lump. Presentation, usually the features are very similar to appendicitis, but you will get a lump in the right iliac fossa. When you do an examination of this patient, you usually get a lump in the right iliac fossa, and you mark it. Very important that you mark it. It will be a tender lump. There may be fever if there is abscess formation. Now, we do not do the surgery in case of appendicular lump because if you remember, due to the inflammation, there may be severe adhesions and difficult to separate, dangerous to operate. There is a chance of fecal fistula if you injure the cecum or the ileum. Maximum chance of iatrogenic injury. So we will do a conservative approach. That means we will do a surgery, but not now, later. First, as I have just discussed, if you remember, mark this area. Very important is you mark this area because we want to compare whether the size is increasing or not. First, mark the size. And then we give the patient conservative treatment and resuscitate, nothing but oral fluid supplements, antibiotics, analgesics. Monitoring is very important. Monitor the patient, pulse, temperature, blood pressure, fluids, input-output chart. Then allow oral fluids if the patient is improving. If there is vomiting, give antiemetics. But the size of the lump decreases. Then after 6 weeks, we do an interval appendisectomy. Interval appendicectomy. If there's a failure, think of other causes. This regimen, what we have just discussed, is called Ochsner-Sharon regime. We will discuss Ochsner-Sharon regime. Now, when we will stop the conservative treatment if the patient is deteriorating. How will you understand the patient is deteriorating? The patient will complain of pain. There will be tachycardia. There will be pyrexia. Abdominal pain will increase. Size of the mass will increase, and other features like vomiting will continue. If the signs symptoms are deteriorating, then you have to stop conservative treatment and go for surgical treatment. Differential diagnosis of appendicular lump. You remember we have already discussed the differentials or different things that are found in the right iliac fossa, namely carcinoma cecum in the elderly, Crohn's disease in the younger patient, and another thing is intestinal TB. Very important. If somebody asks you about what are the differentials of an appendicular lump, talk about cecum, Crohn's disease, and intestinal TB. There are definitely the others, but these are rare. But twisted ovarian cyst in female can happen. Remember to talk about this. This is also an important differentials. There are different types of appendicular malignancy. Most importantly, that usually I haven't seen an appendicular adenocarcinoma, but there are many carcinoid tumors. This is very, very important. Carcinoid tumors are the commonest in appendix. This is a neuroendocrine tumor. Just in short, these arises from the argentifen or the Kulczewski cells of the crypts or liver coon. If you get something like that, do an appendicectomy. If it is less than 2 centimeter, if it is more than 2 centimeter, then go for right hemicolectomy. This is very important. Less than 2 centimeter, go for appendicectomy. It's more than 2 centimeter, go for right hemicolectomy. So if you guys have any questions regarding this, you can always ask. Um, you can. I'm sure there's a lot of questions because appendicitis is quite a large chapter. You can, if you have any further questions, you can ask me, and certainly we can take another class if it's necessary. I think Bailey and Love is a very good book. You can read it from that book. And no other further, any other at undergrad level, other books are not necessary. But certainly about the operative surgery, you can go through the Farquharson. That's a very good book. So thank you for your time. I'll see you next week.